Go ahead and get started now. Thank you for joining us. This is the Q&A portion of the presentation, Addressing Mental and Behavioral Health Needs, Collaboration is Key. I'm Michelle Crawford from AMCHP. I'm going to be asking our presenters to introduce themselves in just a moment. I'll be sharing any questions that might have been shared in the questions tab of the presentation. If you didn't have a chance to submit your question or you wanted to hang on to it for this discussion, that is completely fine. We will ask you to either raise your hand so that you can unmute and ask your question or engage in the conversation, or feel free to use the chat if you prefer. So I'm going to pass this to my colleague and one of the presenters, Sabra, and then have her call on the other presenters to introduce themselves.
Awesome. Thank you so much, Michelle. So we just wanted to take a chance to introduce ourselves because we changed up our lineup a little bit for the Q&A. So my name is Sabra Inkner, and I'm the Associate Director for Clinical and Community Collaboration here at AMCHP. And I will pass to Kathy.
Hi, everyone. I'm Kathy Janis, and I'm the Manager of Bright Futures Implementation with the Bright Futures National Center at the American Academy of Pediatrics.
Thanks. And Hannah?
Good afternoon, everyone. Hannah Goldberg. I am with GEARS, the Georgia Early Education Alliance for Ready Students. We are a statewide early childhood policy research and advocacy organization.
So thanks so much for joining us. And Jen Zubler?
Hi, I'm Jen Zubler. I'm a pediatrician in Georgia, and I get to do work with the Georgia chapter, the Academy of Pediatrics, and then also with the National American Academy of Pediatrics, and also do some consulting work with the CDC's Learn the Signs Act Early program.
Awesome, thank you. And Kathy W.
Hey, I'm Kathy Wellborn. I am the Children First Team Lead here at the Georgia Department of Public Health. Thank you.
And Linda?
Hi, my name is Linda Tran. I am the Title V Analyst at the Georgia Department of Public Health.
And last but most impressively, with some serious presentation skills, you guys have no idea, is Sharita.
Good afternoon, everyone. I am Sharita Summerhour, and I'm the Early Childhood Literacy and Language Acquisition Stake Lead with the Georgia Department of Public Health.
Awesome. Thank you so much. And I will turn it back to Michelle. And do encourage everybody to introduce themselves in the chat, if you would, please.
Yes, thank you, Sabra, and thank you to all of our presenters. I am going to continue to monitor the questions tab in the presentation for those that may be still in there. But at this point in time, I do not see any questions that are posted. So again, I'm going to invite you all to either raise your hand so that we can call on you to unmute and ask your question, or to go ahead and type into the chat box. To get us started, I do have a question. I know I introduced myself earlier with AMCHP. I'm the Senior Specialist for Family Leadership Initiatives. I have been with AMCHP for over 11 years now, and my portfolio is all around family engagement and partnership. So my general question for all of you, based selfishly on my focus area of interest and passion, is if you want to share a little bit about I know that I heard a little bit in the presentation about, I wrote it down, including family representatives and then family-centered strength-based approaches. Does anyone want to, any of our presenters want to share a little bit about your efforts to work with parents and caregivers in setting your priorities and or partnering with them in the work that you do?
So as a pediatrician, we love Bright Futures as our framework, but we know that it's really engagement and working with families that's the most important, so that they can set the priorities that we focus on. So we've done some projects, which you heard about during the presentation, which are just expanding physician and other pediatric clinician knowledge of how to do that. and how to really transform practice to be family engaged and family and patient-centered care.
And is anybody from, oh yeah, I was gonna say from Georgia DPH, so Kathy W, go ahead. Yeah.
Sure. So our Children First program, which is our 0 to 5 program, that's going to be completely voluntary for parents, and it's going to be, based on what we've identified, but also what are the parents' concerns? What are they doing? Getting feedback from them is going to be absolutely essential in moving forward with that child. So I think, we've all heard things and seen families that maybe are at a different place with that diagnosis or condition. And I think listening to them and their concerns and being able to address it from, where we are with a child and what we can do and what we can't do, setting those realistic expectations. And being honest and transparent. We know that they are the parents and we're letting them kind of lead the charge there.
Specifically, Help Me Grow Georgia, which is a Title V funded initiative, specifically promotes children's mental health and well-being. We do this by empowering families through linking them to socioeconomic supports and resources to combat homelessness, poverty, and food insecurity. By ensuring that the basic needs are met, we are increasing resiliency and fostering positive home environments where parents can become the best advocates for their children and increase awareness, developmental screening, and gain access to behavioral health and resources. We like to say that healthy families in particular grow healthy children, and that's the work we do at the Department of Public Health through Help Me Grow.
Yeah, I would just say from the Bright Futures perspective, as Jen said, that many people use it as a framework, and that's really a hallmark of Bright Futures, is really addressing the family's concerns first. So really having a chance for them to voice their concerns and really prioritizing the primary care visit around what the parent needs. So especially if you want, to build that therapeutic relationship, you really do need to know what the parent needs to address. If they want to talk about toilet training and you want to talk about safe sleep, until you talk about toilet training, might not get to safe sleep. So, or you might not have a parent hear what you want to talk about. So you really do need to partner. On the basic level of working with families and engaging families, it's really respecting their time and, pay for them to come to meetings, support childcare if they need it, really have them, they're acting as a paraprofessional in the role that you're asking them to do. So really, respect that and not assume that they're going to volunteer their time out of their sense of advocacy or because they know that they want their foot in the door, and also give them a very specific role and make sure that their voice is as important as anyone else at the table, because it can be very intimidating for a parent to come in to a group of professionals. So those are very basic things, but I think it's things that people should keep in mind when they're trying to do engagement around bringing families into any project.
And then DPH here in Georgia and stuff, when we've done some of these collaborative projects, we've also been able to involve the family voices here in Georgia to help us with that piece and help identify best practices for engaging families in that higher level work versus one-to-one, but being an advisor for any work that we do.
I also do want to add at the State Health Department that we do have a family support coordinator who works really closely with our children and youth with special healthcare needs director. We also, within the last few years, have been working on a family engagement learning collaborative, which consists of 4 different phases. Through Children's Medical Services. The four phases are communication, family activity, advocacy and leadership, and then parent advisory. So that work is going on as well.
Great, thank you. Yeah, I'm hoping to hear that bridge of from both the direct care perspective and then as well knowing, with Linda, you being the Title V coordinator, that you'd have that perspective of where families are engaging directly with the priorities of the Title V program. And so the other question that I have is, we still want to hear from all of you here. Is I saw some of the introductions that we've got some folks who are from different Title V agencies that have joined us. We've got an EPSAC care coordinator, and just wondering, if any of you just want to share what resonated maybe about what you heard on the presentation, or some reflections of your own programs, or things that are going well for you guys in your own programs that maybe you would like to share, because we would definitely love to hear about that as well. Yeah, it's Cheryl.
Yes, I'm Cheryl Jones. I'm a pediatric nurse practitioner. I work with child health specialty clinics in Iowa. And in Iowa, we have CHSC has regional centers located primarily in rural areas, underserved areas. And we do gap filling services for children and youth with special needs. And I've been in this position for over 40 years, and I will tell you the complexity and the severity of what I'm seeing in young children with behavioral and mental health issues is alarming, to say the least. And given all the other stuff that's going on now, the anxiety in kids and parents is high. We have in Iowa, extremely fortunate to have the First 5 program with the Department of Public Health. And I know James is on, he might be able to talk a little bit more about that. But they work with primary care providers to encourage screening, particularly use of the ASQ3 and the ASQSE and the AMCHP to get kids identified. The issue we run into is you can identify kids, then where do they go? In rural Iowa, I don't know about you in Georgia, but the number of providers available, particularly to see young children with mental health issues, is just not there. We have no ABA therapy in my entire region of the state. It's about 16 counties in Iowa. One ABA provider 2 hours away from Atumwa, they've got a 2-year wait list. What are you finding in terms of, the screenings are one thing, but then what do you do is another? And what type of systems or whatever you're doing? We have some collaboratives in our area where we try and work together. We have a Children's Mental Health Wellbeing Collaborative of 12 counties in Southeast Iowa, where all kinds of providers, education, human services, health, to talk about how do we work together? What do we do? But we are struggling with providers. And I'm just wondering what you're finding, if you have any suggestions about how you're doing this in Georgia.
Thank you for sharing that perspective, Cheryl. And I do not think that you are alone or unique in those challenges. So I do invite our colleagues from Georgia to share kind of their perspectives on that.
So I know I have quite a few colleagues on the line that probably have information to add as well, but I'll take a shot at that one. So I know you heard me talk about the Infant Early Childhood Mental Health Task Force that was convened in 2021. One of the areas and recommendations really focused on the need to support and prepare early childhood workforces, specifically providing core competencies in the areas of early childhood. The Georgia AIM initiative will offer pathways for infant early childhood mental health training opportunities at all levels of the early childhood workforce, so that we can encourage child health care providers, early childhood educators and home visitors, as well as anyone who's in that early intervention area, to grow their capacities and be able to really support children and families. Because really, to do this work, we have to train. We have to make sure that the workforce is out there, like you said, to link resources. So Help Me Grow is out there, growing connections, growing ability to link, but we have to have someone to link to. And so that Infant Early Childhood Mental Health Task Force was specifically tasked with trying to decide what that's going to look like now in 5 years and even in 10 years, to make sure that we're prepared to support children, especially coming off the back of COVID. We understand the situation we're in. I mean, there's no greater fear for me in this space and place is to refer a family and not have anywhere for them to go. So that's what we're working towards. It's a work in progress at this point.
I'm going to jump in. I don't have the greatest data or probably as much as you'd like to hear, but I do know that for our children with special health care needs, especially with our CMS program in particular, they've been working with our Office of Telehealth and Telemedicine for years, even prior to COVID. So they did have a system in place for getting access to remote care for the children that need specialty care, especially for those in the rural counties where it is more difficult for them to see a provider or they would have to travel longer distances. But I do know that our CMS program has a really good system in place with our Office of Telehealth and Telemedicine. There is, especially in Waycross County, which is in South Georgia, is where they got this all started.
I'll just build on something that Sharita mentioned. You know, we know the workforce piece is a huge challenge, but we also know that, you know, children need support across a number of settings. And so that's why, and, you know, I'm speaking at this issue from probably 30,000 feet, but I think really underscoring the importance of those collaborations and of cross-agency collaboration specifically. So for example, much of the work that we've been able to do in the infant early childhood mental health space is a direct result of work that we have done with both DPH, but also the Department of Early Care and Learning, because we know that children are also in childcare settings. So I think that has been really crucial, you know, as we're thinking about opportunities for collaboration and for training, is to both build up that infrastructure and awareness across the state. You know, we've been able to do that within our state legislature, for example, and also across, as I mentioned, several different state agencies to you know, be creative in the funding and thinking about how you're supporting the current and future workforce to get training that is specific to the needs of very young children.
And I've been in Georgia long enough now to see some of all the hard work people have done over the years, you know, to see an increase. It's long ways to go, but people have worked really hard, really worked across tables, and you can see some things increasing. And so I'm sure all the infant mental health work and stuff will follow the same course and pathway where you implement policy and people do come. And so for ABA therapists, we are seeing availability increasing throughout Georgia, which is a great thing to see. And then as a pediatrician medical home, you know, and actually have a child with disabilities, just that not to underestimate, even if all the resources aren't there and they're in development right now, that whatever the early childhood professional is or medical home is, that they can support that safe, stable, nurturing relationship for the family as they go through this access and trying to navigate systems of care. So always try to talk to other clinicians about the importance of still screening, still identifying, even if we don't have the resources yet all worked out.
Thanks everyone for those responses. I just wanted to make sure that we noticed Stuart's question. And I suppose this could be for our presenters, but also any of you on the line here with us, because it's really a state level question, I guess. He asked, what are we doing in any state to stop the revolving door that the targeted workforce tends to be? So certainly any of our presenters, if you want to respond to that, and then I would invite others to raise their hand to respond, or again, please feel free to use the chat. And Stuart, if you have any sort of follow-up question or want to elaborate on that question, certainly feel free to unmute and do so as well.
Oh, this is Sabra, and I'll take off my AMCHP hat a little bit and put on my Alaska hat from my past life, where I worked for the state of Alaska and lived and worked in Nome as a public health nurse, and actually used the Bright Futures curriculum in that role. You know, I think one thing that I would like to see, in addition to what's been shared in expansion of the use of telehealth, and which is not a panacea by any means, but there is a lot there. There's a lot of potential, especially if we can get you know, licensing boards and stuff to stop being quite so territorial with things like cross-border licensure that could really make some massive differences in people being able to access care where they are, irrespective of where the provider is. That I think we really lost some opportunities, a lot of during public health emergencies in various jurisdictions. Some of those restrictions were lifted or waived or lessened, and there was a really wonderful impact, especially for some families with that needed a lot of specialty care. And we're losing that now, unfortunately. That I don't know of any state agency that worked to make any of those changes permanent. So I think that there's a lot of effort that needs to happen there. And then the other thing, and again, this gets fought at, you know, within the licensing and regulatory world, is expanding scope of practice for professionals. And, you know, again, when I was a public health nurse in Colorado, my role in EPSDT in EPSTAT was to try to get my clients into a medical home, which in suburban Denver was hit or miss, you know, and keep it, you know, they needed to have Medicaid or something for people to be, you know, consistently seen. And it was a challenge. When I moved to Alaska, all of a sudden, as an RN, not as an advanced practice nurse, I was responsible for the well child exam. You know, that meant that I worked for the state. We could see anybody. Billing was not the priority. And we did, and we were able to get, you know, kids in the most remote parts of the country seen, screened, vaccinated, you know, do anticipatory guidance and those kinds of things. And so I really just want to, you know, to me, that's a thing that, you know, both, it's actually the same thing, which is licensing boards and regulations on scope of practice and where people can practice, between the restrictions on telehealth as well as the restrictions on, you know, licensure levels and what people can do. So I would just encourage anybody who works in an agency that has any pull there, or who is a licensed professional who's perhaps membership organization or whatever has ever fought against somebody else having an expanded scope of practice. I know sometimes nurses fight against, like, paramedics being able to provide some services in rural areas, and that's ridiculous. We should be encouraging it. So yeah, that's my contribution to your question, Stuart.
If I can follow up to my question, I was talking out of experience with the idea that there are those that we have those positions, but our biggest challenge is keeping them filled. That not in my experience, if those positions aren't being if those positions are not held by any one individual for more than 2 years, maybe, I mean, or then it's good, then the times when it's not full, which is about 75% of the time, it's going to impact the whole rest of the staff and what they do. And I think that it ultimately decreases the quality of the care for what we do. We might it would have been at times it would have been better to when we didn't have those positions. Yes. So I was talking about within my own experience of navigating through seeing revolving doors here at the Human Development Center, and also myself, my transitions role was through a bunch of positions that through a bunch of specialists, so-called, that were themselves in revolving door positions, and in the end did not help me one bit.
Stuart, this is Cheryl Jones again, and I know exactly what you're talking about. And in that collaborative I talked to you about, we were having discussions about workforce shortages, and not just revolving doors, but moving, if someone gets a therapist, it's often from one of the other partners. They move to another organization within the area. What we went talking to our legislators and saying, we have a huge workforce problem, and there's some issues we need to be looking at. We need to have, ability for people who locate in these rural areas to get funding, that kind of thing. So what we did is we did a survey of our organizations and said, are you having shortages? Is this affecting your ability to provide services? Is it affecting your ability to collaborate with others? And we shared that information with legislators who said they really knew it was bad. They had no idea it was this bad. I don't know if that's a strategy you could look at with partners to say, and we had a whole set of questions and we shared it. And several places in Iowa have done this, to take to policymakers and say just what you were saying, Sabra, about what are some of the barriers to people practicing in these areas. There's these scope of practice barriers because this discipline doesn't want that discipline to do this, even if they're qualified. So we found that getting data about what is it affecting, and when every single organization at the table was affected, and it was receptionists, it was therapists, it was home visitors, it was nurse practitioners, it was physicians, it was everybody, it made a lot more of an impact. I don't know if that'd be helpful or not, but we found that to be one strategy that seemed to at least help us a little bit. Not that we got all the legislation we wanted, don't get me wrong, but at least we had data to take and say it is really bad in rural Iowa.
We're encouraging in our program, so not just your formal HR exit interview, but actually in the program, when there's staff turnover, to do like an informal program exit interview and to ask open-ended questions like, we should start, we should stop, we should continue, and get some more information and feedback on the program. While we know that some people it's salary or other types of challenges as to why they're leaving a position, programmatically, if there's something that we don't know, oftentimes when someone's resigning, we think we know why, but we are not stopping to ask those questions. We're letting HR do that formal exit interview, but we'd really like to get some more informal feedback in an informal type of exit interview at the program level.
And I just want to pipe in, Stuart, were you able to finish what you were saying? I want to make sure that.
Yeah, yes, that's what I wanted to say.
Awesome. So Michelle.
Yeah, thank you. We have just about 1 minute left. I've done sort of a scan through our room. I don't see anyone with hands raised. I see a comment in the chat from Jen. I'm sorry that individuals and families do experience this. We all still have a lot of work to do sharing the impacts of workforce shortages and finding innovative solutions. And I will just add to that, a comment was made during the presentation about people sort of being a little bit, scared or intimidated by the idea of mental health challenges or issues in young children. I think we also have so much work to do when it comes to stigma in general, not only with that population, but across all of our populations, all of our age groups. There are general stigma barriers, there are cultural barriers to sort of identifying mental health challenges and needs, as well as accessing treatment, which is so unfortunate, especially in the time of this ongoing pandemic and unfortunate traumatic occurrences like the loss of life in Texas. So there's a lot of mental health need out there, and I do hope that we collectively can continue to work to reduce the stigma, to support that it is okay to have mental and emotional well-being, and that is something that we should all focus on and be able to talk about. So I want to thank our presenters for a really amazing presentation. We're going to go ahead and end. I want to be respectful of our presenters' time as well as all your time. Encourage you to take a break, have a little bit of self-care before what I know you're going to join our final closing plenary, Shaping Our Future, which begins at 3:45 p.m. Eastern Time. So definitely, take a break, check in with yourself, check in with your loved ones, stretch your legs, whatever you need to do. And hopefully we will see you back in just about 20 minutes for our closing plenary. I hope you all have a wonderful day. And thank you again so much to this amazing panel of presenters for a wonderful and informative presentation. Take care, everyone.
Thank you all. Thank you so much. And yeah, thank you to all of you guys, to the Georgia team that is still here. You guys are, as you know, the heroes and rock stars. So it's very, very, very much appreciated. Thanks, guys.
Thank you. Sharita. Never mind. Thank you.